Good afternoon, doctors. I'm Ajay Gupta, Country Manager for the Cadila Pharmaceutical Limited, based in Uganda. On behalf of Cadila Pharmaceutical Limited, I welcome you all. I welcome Professor Ochama, the President for users, and welcome to all panel members. As you know, we are here for an exciting program, that is the launch of first ever gastro-specific consensus guidelines. And from here, I'd like to hand over the session to our marketing manager, Mr. Pushkar. Please.
Thank you, Mr. Ajay. And on behalf of Cadila Pharmaceuticals, I, Pushkar Gupta, Assistant General Manager Marketing, would like to welcome all the delegates, all the panel members, and especially the President of Uganda Society of Gastroenterology, Professor Ochama sir, for this Uganda Society of Gastroenterology Consensus Guideline launch. Today, we feel privileged to amongst the most important key opinion leaders, most important doctors of our fraternity. And today we are going to have the exciting discussions by all the panel members on the algorithms. So before I unveil the entire agenda, I'll be having our medical advisor, Dr. Vipin Sethi, who will be briefing on the need of Uganda gastro guidelines. And thereafter, I'll request Professor Ochama to please unveil the entire session. So without taking much time, I'll hand over the session to Dr. Vipin Sethi. Dr. Vipin Sethi, over to you live. Dr. Vipin Sethi, over to you now. Yes, sir, you are audible. May I request technical team?
So,
Yeah. Thank you. Thank you, technical team. Over to Dr. Vipin, please.
yes, so thank you very much once again, Mr. Pushkar, and a very warm welcome to each one of you, especially the team sitting there, together at one place. And I would just like to set the tone and brief, this is a very important activity for all of us. It took us a lot of time to come out with these algorithm guidelines, and we wanted to have an objective wherein we can give everybody a very brief booklet so that people sitting anywhere across Uganda can follow these simple guidelines. And as you understand very clearly, gastroenterology, like any other segment, is a very dynamic therapy, and treatment modalities are changing every day. While treatment modalities are changing, there are so many guidelines on this which are also updating. So based on those guidelines, treatment modality, and experience of all the panel members who are sitting there, there were about more than 15 panelists, those who have more than combined put together maybe 300 400 years of experience. And this is how in last 6 7 months we met almost every 2 weeks, and we gathered all the information what is available in the guidelines, whatever is their experiences, and try to putting down everything in a very simple, a flow diagram, so that anybody sitting anywhere can simply follow these flow diagram and manage the patients who come directly, whether it's to the primary center or secondary, and then they can be sent to the tertiary care centers to all of this. While we did this all, it is, believe me, a lot of hard work behind this with all the people you are sitting there. Professor Chama, if I have to take names, Dr. Okelo, Dr. Sabrina, Dr. Suzanne, Dr. Kalika, Dr. Raymond. I'm all names I will take, but I'm sure they're going to come to you one by one on this. and I will not take much of a time. I'll come back again to you while we will discuss, a lot of queries and all. At that time, I'll come back to you. But before that, I would like, our very learned and renowned friend, Dr. Ochama, to come and give you all the brief and presentation and the background. So with this, without taking any much time, I would like to call upon Professor Ochama to come and please brief all the audience about what all has happened and how we will go. Professor Ochama, over to you. He's a very learned man, and I'm sure you all know he doesn't need any introduction from us. Once again, Professor Ochama, welcome.
So, thank you very much, Dr. Bipin, and the members who are here. I just want to be sure that I have the presentation. So I want to welcome every member that is here. We have been working on this program for, I think, almost 3 years. You know, these gallant members who are sitting in this room have met, I think it was like every week, making discussing, the algorithms and going back and forth with the help of Kadila. We really appreciate this, and I want to start by also saying this guideline, our hope is that it's going to be very helpful to the medical fraternity. It's very simple, and I think it is very easy to follow. And all the members here, in their different capacities, were able to make their contributions to this effect. So I think the presentation that I would like to make. So as we wait for the presentation getting uploaded, I want to say that this program, it is a loaded program with very many presentations within the time that has been allocated. But I think we should be able to manage the time. I know that some of the
Professor Ochama, can you see your presentation? Can you all see? Is it visible?
Yes, I'm able to see the presentation.
So you just guide me when we need to change the slides. I'll do it now. Thank you.
Okay, thank you. So I'm just going to set the stage for the launch of this guideline by talking a little bit about some of the spectrum of the digestive diseases in Africa, the status, and also the challenges of management of some of these. Things have been changing over time. I'm not going to present each of these guidelines, but I will talk a little bit about some of the conditions that we see. Next slide. Yeah, so I'm going to talk, give a preamble a little bit and talk about peptic ulcers and mention things to do with the Helicobacter pylori, GI bleed, functional GI disorders, GERD, obesity, and I will summarize this presentation. Next. And it is going to be mainly about Africa, what we are seeing in Africa.
Recording in progress.
There is considerable heterogeneity in peptic ulcer diseases. Prevalence is not very clear in most parts of Africa, and with no clear geographical patterns. There are differences in peptic ulcer disease, even within the different countries of Africa, despite the universal high prevalence of Helicobacter pylori. Most of the studies that have been done in tertiary centers, showed a higher prevalence when compared with what we see in some Western countries. There is some ongoing decline in peptic ulcer disease in some African countries, and actually that is what we see, even where H. pylori is really very high. Other factors, of course, have got to be considered, including the NSAIDs in a local, and of course, some of these over-the-counter medications that we take, cigarette smoking, alcohol, and other aggressive factors. Next. Of course, we are talking about the World Digestive Health Day, and that is today. It's supposed to be on 29th, which is supposed to be on Sunday. We decided to hold it today. This year, the theme is colorectal cancer prevention and getting back on track. It is celebrated every 29th day of May, and the aim is basically awareness, creation awareness. In this awareness, today we are going to be launching this book, which we have called the Best Practices in Gastro in Uganda, the Consensus Guideline, and that is a very important part of the Digestive Health Day. Next. Now, when we talk about H. pylori, the prevalence really varies between countries. In developing countries, we have about 70 to 90% prevalence. But when you compare this with what we see in developed countries, 25 to 50%, East African prevalence range from 46% to 75%. Of course, this infection causes peptic ulcer disease and gastric cancers, including also mucosa-associated lymphoid tissue lymphomas. Next. In Uganda, we had a study in 2001 at the GI, at the endoscopy unit in Mulago and also in Zambia Hospital. And we recruited 100 patients at endoscopy units of these hospitals. And at that time, the main indication was dyspepsia. Now, the findings, and we used actually the antibody test. So these patients would come in and then we test them. We ask them to participate, and if they agree, we would just take their sample and we test for antibody. But then they go ahead with their endoscopy. 80% endoscopy anti-H. pylori positive, 10% had peptic ulcer disease. But when you look at those who actually had peptic ulcer, 80% of them actually had H. pylori. Now, this is important for us to note that not all H. pylori positive is equal to ulcer. And not all, when H. pylori is negative, it doesn't necessarily mean there is ulcer. And this is important, and I hope that this guideline will help with some of what we are seeing where H. pylori is being tested in everybody and being treated for ulcers. The next slide shows what also happened in Mulago Hospital later on in 2014, where at the endoscopy unit, we recruited 167 patients with dyspepsia, and this time using stool antigen for H. pylori to look for H. pylori, and also endoscopy was done, and histology for Helicobacter pylori was performed. Now, the stool antigen was positive in 33.5% of these patients, histology in 32.5%. But peptic ulcer at endoscopy was 19%. The rest had 32.5% had normal findings. Now, this is study, the conclusion, and you can read it because it was published in African Health Science Journal. The, the, the conclusion was that the validity of the stool antigen in predicting Helicobacter pylori generally is low, with an overall sensitivity of 55.8 and specificity of 74.2. Validity was higher in predicting diagnosis of peptic ulcer disease. But again, even when you look at that, it is still low. It's, the sensitivity 59% and specificity of 72%. So not all H. pylori positive is equal to ulcer. Next. Bleeding. Upper GI bleed is actually the commonest that we see. Acute GI bleeding requires emergency resuscitation, investigation, and management. Fortunately, especially for upper GI bleed, most times upper GI bleed tend to stop spontaneously and may not actually require surgical intervention. Emergency endoscopy is both diagnostic and therapeutic, and definitive management is indicated by the overall risk of rebleeding and morbidity. And operative intervention is required following failed endoscopic control, or sometimes also depends on the cause of this GI bleed, really. Next. Functional gastrointestinal disorders. Now, these are also disorders which are called disorders of gut-brain interactions. They can present as one or both of irritable bowel syndrome or functional dyspepsia. And next slide. So when we are talking about irritable bowel syndrome, these are really a group of symptoms that include lower abdominal pain that may go away after having a bowel movement, may include bloating, constipation, and or diarrhea, not diagnosed from investigation. You do investigations, and they're all normal, but the patient is still coming back to you, complaining. Functional dyspepsia is really pain, which is usually above the belly button, and may be bloating and nausea, often without vomiting. Sometimes it is called non-ulcer dyspepsia or nervous stomach. Feeling of fullness can prevent normal meal eating, and pain does not get better after emptying bowel. Now, these days, things are getting worse because many patients are coming again, and usually the thought is either poison. Poison has become very common, I think, and then cancers, and then there's another one, which I forget. So they keep coming and do tests, and they're all normal, and then they continue complaining. So next slide. So this was a study which was published last year, involving 33 countries with 73,000 participants. Now, these guys went on to look for, they sent out questionnaires on internet, and in some of the countries it was physical actually. But they found that more than 40% of persons worldwide have got these problems that we are talking about. And this was similar in those who answered physically and those who answered by internet. And it's more in women than in men. I think this is a disease of the gut-brain axis. And so I think women are worried about what the children are going to eat, and also what their husbands are doing somewhere out there. And so they come in with some of these symptoms. Next. GERD. It's also common. It occurs when the reflux of gastric contents into the esophagus and overall cavity results in oral cavity results in troublesome symptoms and or complications. It presents a common reason for patients visiting primary care providers. Estimates of the prevalence of GERD in Africa and Middle East range between 7.6 to 61.8%. Now, this I'm mentioning it because recently there was a paper that was published in Feb this year. In Africa and Middle East, they were asking opinions of gastroenterologists on GERD and GERD complications. And you can, next slide, please. So these are the views, in terms of the etiology, the gastroenterologists, host factors. They're talking about old age, obesity, psychological stress, environmental factors, including smoking, herbal medicine. Herbal medicine use is very common in this area. Caffeine, H. pylori eradication. Again, I should say this, that H. pylori eradication actually leads to reflux. And so you do not, I see that sometimes we are treating reflux with H. pylori eradication. You're actually causing more reflux in these patients. Of course, the socioeconomic factors, unemployment, living in rural areas probably is more protective as people eat more food which is organic than organic food that we eat in some of these areas where we are living in right now. Next slide. Next slide. Okay. So from this AMAGE is, no, go back. So from this AMAGE is African and Middle East Association of Gastroenterology that I was presenting. Those are the etiological factors I was presenting is from that AMAGE group. GAD is multifactorial with many contributing factors. Data on the symptomatology of GAD in AME are limited. Heartburn and regurgitation are the most common symptoms. Atypical and extraesophageal symptoms, including nausea, epigastric pain, dyspepsia-like symptoms, cough, chest pain, sleep disturbances, and bloating. These are the ones that were actually identified in the study. And of course, the number of possible risk factors which were identified, as I mentioned. But then, because these studies took place in a number of countries, there were variability between the studies, which could actually, in a way, affect the putting together of the risk factors. Urbanization and adoption of Western diet may be an important contributing factor for GAD in patients, especially people who are now living from the rural area and going to the urban centers. Next slide. What about obesity? Across the continent, the share of urban population is projected to increase from 50% by 2030 and 60% by 2050. So eventually, by 2050, half of the population in Africa will be obese. Lifestyle changes in the urban population, of course, is associated with rapid urbanization, which means that actually Africa is having a looming epidemic. And we see this from time to time. And so we are going to get into issues of managing these kind of patients. Now, sometimes we don't know, most of us are not in that kind of, you need a lot of counseling, nutritional support. Once in a while, we send them over to the surgeons to try to look and see what they are going to do. It is not easy, and I can see that this is going to continue happening. The combination of all these contributes to the rising burden. People are sitting back and not doing a lot of activities, and they are eating these high caloric fast foods. And so when you combine these, things can only get worse. Next. So you can see that one. This was a study that was published in 2012, a relatively old study. It is more prevalent in the urban settings because of what I've already mentioned. That study even showed that actually it was a West African study that was showing people who have gone to the Netherlands, Africans in the Netherlands, and the ones back home. And certainly there was more obesity amongst those who actually traveled to the Netherlands than the ones who remained behind. So correlationship between obesity and chronic disease certainly occur. And in our case, we are talking about many things, including GERD, including fatty liver diseases. And these days, people come to the consultation room and you see them, you can actually diagnose fatty liver disease as they walk in. And then they say, but you know, the scan said my liver is a bit looking brighter and it is bigger. And I say, yes, I saw it while you were walking in without abdominal ultrasound scan. So that is, those are some of the issues that we are going to be facing, and we are going to face more and more. I'm sure I'm not alone. Next slide. So really, we are having changing trend of GI diseases in Africa, and limited resources and materials. Actually, I am a bit worried because we are going to find it very difficult to cope up with this. And we are going to have large number of patients and few clinicians. We don't have many guidelines to actually manage these people. And that is the reason why we decided that we should develop some kind of an abridged guideline. Now, this guideline may not sort out everything that you need to know, but then the guideline has got references. Sometimes when there's something that you are not getting well, please go back and read those references which have been indicated, and they should be able to help. And also, the guidelines have not contained all the diseases, the GI diseases. So we looked at the common conditions that that people get, that we are receiving in our different practices. So thank you very much for listening to me. That is what I wanted to tell you. Basically, what I did was to introduce the spectrum of diseases before we begin to talk about briefly about the guidelines, the guideline that we have developed, the algorithms that we have developed. Thank you so much, and I wish you a very nice time during this time of the meeting. Thanks.
Thank you very much, Dr. Chama. I think very nicely brief about this. So, Pushpa, you are going to take it from there and call your colleagues, or you want me to call colleagues from here on each of the flow diagram? Maybe we can start from upper GI.
Yeah, thank you, Dr. Vipin, and thank you, Professor Ochama, for taking us through the prevalence of GI prevalence in entire Africa, especially in Uganda. Now we are set for the panel discussion for the algorithms. So, as per the agenda, we'll be starting the algorithm presentation with upper GI bleed. I'll request Dr. Michael Okello and Dr. Wasimbe Francis to please initiate your discussion on upper GI bleeding. Thank you very much.
Thank you very much, Professor Chama, for the discussion. As highlighted, the guidelines are basically brief, and they guide us on management of all these different conditions. For upper GI bleeding, depending on how the patient presents, whether acute or chronic, you look at the etiology, whether varicio or non-varicio, and manage accordingly, as simplified in our algorithm. So I will not delve much unless we have questions on it, but basically that is my comment. It's just that as we do this work, I want to ask my colleagues if they are seeing patterns of, for varicio upper GI bleeding. Of course, we look at the liver etiology, cirrhosis, from either hepatitis B, hepatitis C, or alcohol. But I'm seeing a few cases of non-cirrhotic portal hypertension. And these ones, our algorithm may not capture everything, but these ones with non-cirrhotic portal hypertension who have these esophageal varices, we realize there's no need to do endoscopic variceal band ligation because you'd have to do repeated sessions. So those ones would benefit from being sent to the surgeons, Dr. Chiduka here, at least for proximal splenorenal shunt, because then there you're dealing with a cause.
Uh, Dr. Dr. Michael, we are not able to hear you. I think online you said is online you're not able to hear you. It seems your audio is off.
I just wanted to highlight that aspect of variceal bleeding versus non-variceal in relation to the liver. And as I said, if the liver is cirrhotic, either on imaging, ultrasound scan, CT, or anything, then the patient benefits from the endoscopic intervention, endoscopic variceal band ligation, in addition to the medical therapy, propranolol and the rest. But if it is non-cirrhotic on imaging, then you have non-cirrhotic portal hypertension, and those cases should benefit from a surgeon's input, and the surgeons can do splenorenal shunt, and that deals with the portal hypertension, and the patients get long-term relief from this upper GI bleeding. That is the aspect I wanted to highlight, unless there are questions. Thank you.
Dr. Michael, before we go to anybody else, I have a question. This is Dr. Vipin online from India. So, Dr. Michael, I have a simple question which I see in my practice also many times. Let us assume, after the whole tiring day, you have reached home by midnight. And another 2 hours, right, you are about to sleep or you just slept and you are having some wonderful dream. And you get a call from the emergency saying, Doc, there is a patient who is having black tar stool. So what should I do? So while you stay an hour away or hour and a half away, and you are, in the dreams at that moment of time, what would be your advice or suggestion to the registrar who is there in the emergency? Quickly, what do you like to do? I'm sure immediately registrar can't be understood. So a patient who has come early hours of the morning and having a black tar stool, lots of severe pain, epigastric pain. What would be your advice to the registrar? Over to you, Doctor.
Thank you very much, Dr. Vipin.
Yeah, we can hear you. We can hear you, Doctor.
You can hear me? Okay, good.
Yes, sir, absolutely.
So I've not gotten your question well, but from what I am getting, the implication is the patient presents with acute upper GI bleeding to emergency, most likely in shock.
No, no, I repeat, Dr. Michael, sorry to interrupt. Yes, I repeat. I am not giving the diagnosis. I am only saying a patient middle of the night or wee hours of the morning, 2 or 3 a.m., comes to the emergency with symptoms of or saying he's having a black tarry stool, the dark colored stool, and a severe epigastric pain. What would be your advice to the registrar who is there in the emergency?
Thank you very much. The advice depends on the hemodynamic status of the patient. So someone who comes at 3 a.m., I imagine there has to be a strong reason. They can't walk in if they are very stable. If they are unstable, the first thing is to stabilize them. And once they are stabilized, they resuscitate the first resuscitation, ABC, everything, do grouping, cross-matching, CBC, look at the HP and sort out all the things. And then now we can go ahead and evaluate the patient to look at the cause of the bleeding. And that can be done later when the patient is stable. I don't know whether I've answered you. I can ask my colleagues to give their input.
So thank you, Dr. Michael. I would want some more opinions on this before I share what generally I do. If any more opinions on this,
Uh,
you're absolutely on the right. If any more opinions from anybody.
I can ask my colleague here, Dr. Shtuka, to make a comment.
Uh, the first thing that we need to appreciate from the presentation that was made earlier is that most of the GI bleeding stops, about 80% will stop spontaneously. And the first thing we need to do is to make sure that the patient is stabilized and resuscitated before you go on to trying to establish exactly the cause. And this comes back to the ABCs, making sure the airway is okay, the breathing and the circulation, and making sure you have access to um, good IV access to be able to provide initially at least fluids, and then where necessary and blood products. Uh, for some of these cases, we may even be able to give an initial high dose PPI IV, and then you could also be able to look and see if there's any need. If you've done your CBC and you've seen that there may be abnormalities in the platelets, you may be able to add the tranexamic acid and other products, vitamin K, to help initially. This is just basic, regardless of what the actual cause of bleeding is. Because from the ALG, we do know that the commonest causes are, and those that tend to stop spontaneously, are actually an exacerbated gastritis or a bleeding ulcer. And then we go on to the ones that are more massive and likely to cause destabilization, like variceal bleeding. So when you're looking at the likelihood of the possible causes, you do find that you still have to give those basic drugs I've talked about in terms of the PPI and vitamin K and maybe tranexamic acid. Sometimes when you're now sure that it's most likely variceal, you find that the patient may benefit from talipressine, which is given IV as a start dose for 4 milligrams. And then you can go on to even put in an NG tube to decompress the stomach and allow for the endoscopy to be done, be able to visualize. Because one of the challenges is that the patients come in with bleeding, massive bleeding, the stomach is full of blood and endoscopy you cannot see. So if you put in an NG tube, decompress, it also relieves the pressure on the stomach and also in a way helps to stop bleeding, for example, from a bleeding ulcer. And then it also allows the endoscopist to be able to go ahead and carry out an endoscopy and be able to visualize, because it is pointless to try and put in a scope into a patient who is pouring blood into the stomach. You'll not see anything, and you stand a lot of risks of doing that in an unstable patient, and also getting other problems of aspiration because of the anesthesia you're giving during the endoscopy, and many other complications that can come around from lack of visualizing what you want to see on endoscopy.
Thank you very much, Dr. Chituka.
Thank you.
Vivian, back to you.
Thank you. Thank you so very much. I think very nicely described, Doc. And I would like to just summarize very quickly. So, if any patient like this comes, what I normally do is, as you very nicely said, first and foremost, important is stabilizing the patient and going through ABCD, those airway, blood circulation, and all. That normally this is one thing we have to do. And second most important thing is at that moment of time, we really don't know if there is a bleed, bleed is whether variceal or non-variceal. We really don't know. But whatever is most important here is if it is not variceal and all, so or variceal. Most important thing is to ensure that in the gastric, in the stomach and the stomach part of it, that acid levels are not very high. So first and foremost, most important thing what we need to do is to raise the pH. And for raising the pH, you need to give a PPI, a bonus dose of PPI immediately, whatever patient comes. And as you very rightly said, putting an NG tube and stopping the bleeding is also very important, so that endoscopy is not immediate thing. and we'll have to manage for a couple of hours and then later really see whether you need to do an endoscopy or not. So that's what I would also recommend as you very precisely and nicely elaborated on this to all our colleagues who are sitting maybe little away from Kampala and all where endoscopy facility and their tertiary facilities are not available. Immediately ensure ABCD is done, rice tour is done, they are and a bonus of the PPI is given. And then they can refer or the patient will go on. Thank you very much for responding so much.
Thank
Thank you
you.
once again and over to you.
Thank you very.
Yeah. So now we'll request Dr. Olivia Tutuka and Dr. Okumu Gabriel to please start with the lower GI bleeding, and also will request the other panel members to join the discussion on lower GI bleeding. Thank you.
Yes. One thing about the main thing we're looking at in terms of GI bleeding generally, when you look at the upper GI bleeding and compare it to the lower GI bleeding, most of the problems that come about in lower GI bleeding generally is less aggressive in a sense, tends to be mostly less aggressive, and it's a bit insidious. So most of the patients whom you're going to see will be in a relatively non-emergency state. So unlike upper GI bleeding, which can be massive and eventually cause death, you'll find that lower GI bleeding is a bit um, slower compared to the upper GI bleeding. Although a patient can come, if the patient has massive upper GI bleeding, they can also end up passing stool that is either as melina stools, or they may end up passing even having hematochezia because of massive bleeding. So whenever you're looking at lower GI bleeding, you have to look at it in the context of determining whether it is upper GI that has extended all the way through into the colon, or it's primarily coming from the lower GI. And if it's primarily from the lower GI, then it tends to be a slower history. The patient probably has had the problem for a while, and so they are stable. So the emergency setting, it's rare that you have to have emergency resuscitation of a patient with lower GI bleeding. However, if the patient is unstable, you still have to go through the basics and stabilize the patient. Lower GI bleeding, we're looking at it in terms of the most common causes, and that has to be elaborated from the history to be able to explain whether the bleeding is coming from the rectum or it's coming from the proximal colon or the distal colon. Each of them has a different presentation, and at the end of the day, the mainstay of diagnosing the cause of lower GI bleeding primarily is a colonoscopy. However, we are aware that colonoscopy is not necessarily available everywhere, and there are other investigations that can still help provide us with some information. And I emphasize investigations here because you have time to stabilize the patient and then be able to go through the assessment with time. As I said, because the bleeding is slower and more insidious. So you may have other investigations like the barium enema, which again is cheaper than a colonoscopy. I will not say whether it is more available. I think in terms of availability, it's not as available. So at this point, it is possible that colonoscopy may even be more available than a barium enema in some places. And for barium enema, we'll at least be able to identify if there is a lesion, if it's bleeding, for example, diverticular bleeding from colon diverticulosis. That's a common cause of lower GI bleeding. It may be tumors. You may be able to see the lesion if there's an obstruction or an irregularity in the mucosa. You may also be able, sometimes with lower GI bleeding, we get so taken up with investigations, and we forget the first investigation, which is examining the patient, and most importantly, doing a digital rectal examination. Many times you'll find that actually the bleeding is being caused by a tumor that's just in the rectum where your finger can reach. So you need to be very careful in making sure you examine the patient first before you go for all those other investigations. Put a finger there. Otherwise, if you don't put a finger in there, you'll have to put your foot in it when you miss it. So that is key, especially that is not sophisticated, it can be done anywhere, up country or it's your finger. Then the other investigations, of course, the ultrasound scans, the imaging investigations, just help to tie up what could be the possible cause in terms if it's a tumor and how advanced it is. Sometimes they may be able to see the tumors, but colonoscopy remains the investigation of choice, especially for lesions that are small, that may not be picked on ultrasound or CT scan. For lesions like polyps, these are sometimes difficult to identify on any of those other imaging studies. They might be identified on a barium enema, but as I said, the barium enema may not be as available as we think. You might find that a colonoscopy is actually better. The challenges that we have highlighted is some of the challenges in doing the colonoscopy is preparing this patient. A good colonoscopy relies on a good bowel preparation besides the skill of the person who is doing it. And if you have bowel that is still full of blood or stool, you will not be able to see the lesions. It's very easy for you to miss the lesions. So these patients need to go through adequate bowel preparation. This can be a challenge in patients who are bleeding, especially from diverticular bleeding, because that bleeding can be continuous. And you do know that and diverticular disease is one of those conditions that if you're doing a colonoscopy, you have to be very careful. It's very easy for you to go and perforate the intestine because you're going through a diverticulum without realizing it. So visualization is very important. So if a patient is coming with suspected diverticular bleeding, then you know that the bowel preparation has to be very good. But if you find that bowel preparation has limitations, for example, the patient may be having continuous bleeding and is failing to stabilize, and as you're giving your bowel preparation, they cannot be able to first of all, sustain the bowel preparation, and they may not even have enough time for that bowel preparation to actually work. And you're kind of forced to go in when the patient is not very well prepared. So for the person who does the colonoscopy has to be cognizant of that and work carefully and only go as far as they can go safely. These are some of the cases where you find that ultimately the patient ends up having an urgent surgery, laparotomy, which is partly exploratory, but at the same time possibly definitive treatment. Because if they find that it is diverticular disease of the colon, then you can take out the part that is bleeding. The challenges we have with lower GI bleeding is that there is also this bleeding that does not come from the colon. And it may be coming from the small bowel. Those are difficult to identify. It is very common to do a to go ahead and investigate a patient who comes with features of lower GI bleeding and you do not find the cause from the colon because that's as far as you can go. And possibly the cause can be from the small intestine, or in some cases, patients have vascular abnormalities. These are rare conditions, and you may not be able to see them unless they're actively bleeding. And by the time the patient comes to you, or by the time you send the patient, they already have changes that you may not be able to detect on colonoscopy. As I said, these are mostly, in general, the lower GI bleeding allows time for further investigation and more sophisticated assessment of the patient as for the cause of bleeding. But still, the key things remain that you have to stabilize the patient and establish whether the bleeding is coming from the distal bowel or the proximal bowel. And you should not forget the first investigation, the most important first investigation is a digital rectal examination. Most of the time, you'll actually find the cause of bleeding from that, but then based on what the history is like, if it's massive bleeding, then you may find it's coming from further up, and this patient would need further assessment in a place where they're able to do colonoscopies and any further management thereafter.
Thank you. Thank you so very much, Dr. Olivia. I think very elaborative description and which was very much needed on this. Dr. Olivia, before anybody has any question, there is one query from my side, or maybe a guidance for the medical fraternity or our colleagues who are sitting at the periphery. You know, what would be the three or four highlighted points you would like to guide them if they have to really differentiate between an upper GI bleed or a lower GI. Let's assume same a patient comes with a severe epigastric pain and there is a blood. So three or four very concise points if they have to differentiate if it is possible. Over to you, Dr. Olivia.
The first thing is we know that you have to be able to take a good history. So with upper GI bleeding, you may have hematemesis, they may pass melena stools. With lower GI bleeding, you'll find that it's a history of melena stools. You might find mucoid bloody stools, or it might be frank bleeding. And that history is important in helping you to establish where the bleeding is coming from in terms of the lower GI. If it's bleeding coming from the proximal colon, you may have melena stools. If it's coming from the distal colon, that is from the transverse and the descending colon and the sigmoid colon, then the bleeding is more likely to be fresh bleeding. And also from diverticular disease. I must emphasize history taking because from the history alone, you most times, 80% of the time, you're able to find what is the possible cause of the bleeding. And this should be differentiated from bleeding like from hemorrhoids. It should be differentiated from bleeding like from fissures. And then the key other point I need to emphasize is examination of the patient. You're examining not just the abdominal examination and the general examination, but making sure you do a digital rectal examination because then you're able to identify those lesions even without having to go further on for more expensive and sophisticated investigations, especially tumors in the rectum, around the anus. You may be able to identify hemorrhoids, may be able to identify fissures, and all those are possible causes of bleeding. The third point is in terms of establishing the patient is stable. If there's a need for resuscitation, that should be done. In some cases, you might find you'd still need to give some antibiotic because as these patients bleed, then there's also a risk of sepsis. So you may find you have to give an IV antibiotic or an oral antibiotic as you continue to investigate the patient. And you should be aware of the limitations of what you have with you, what kind of services you're able to offer. And where you don't have them, refer them to a unit where they're able to go on to do the further investigations.
Thanks. I think very nicely. And if I have to summarize this, the most important part is history and clinical examination. And the second most important point which you said, and it is very clearly written. I remember when I used to read a 11th daily or there was a footnote very clearly says, if you can't put your finger, put a foot in it. So I think the rectal examination is very, very important point here. So history, clinical examination, and the PR, which is very, very important. So you have to really whether it's a hemorrhoid, fissure, or maybe something coming from rectum and all, because for finding anything coming from proximal or the distal colon or from the lower GI part of it, you really need to do endoscopy or colonoscopy. So from there, pretty likely. And my second question says, when do you think is the right time to put in a colon inside? When do you think is the right time? Because it's not that immediately you need to do it, but what is the right time to do colonoscopy?
The first thing is colonoscopy should be done when the patient is stable. That's one. Secondly, when you've got adequate bowel preparation. And then Thirdly, when you have the expertise, and that all has to be put into consideration. So I cannot give you a particular time X, but all these are the things that you have to consider in determining whether the patient is right for having a colonoscopy. But again, this has to be put into the context of how severe the bleeding is and how the more severe it is, the more urgent the colonoscopy is required. So you have to get all those things done as quickly as possible. But we do not sacrifice um, the urgency of doing the procedure with stabilizing and making sure the patient can have the procedure done safely. And in some cases, it also means you get the support from anesthesia and other people who are involved in the procedure to make sure that you're able to do it safely.
Thanks again, Dr. Olivia. My last question before, because there was a question from the audience, but like you already answered about that question on the antibiotic. My last question is there any role of PPI? Since when a patient comes to you, you don't know whether it's an upper GI bleed or a lower or what exactly it is. Is there any role? And if there is role, what should be done?
As I mentioned at the beginning, at times upper GI bleeding, if you have lower GI bleeding and you're having GI bleeding from the proximal colon, it can present as Melina stool. In the same way, upper GI bleeding can also present as Melina stool without hematemesis. For example, if the bleeding is from a bleeding duodenal ulcer. So if you've taken a good history, you should be able to have a high index of suspicion as to where the source of the bleeding is. And if you think that it's possible that it's actually coming from the upper GI, then that's where the role of the PPI can come into play, an IV PPI. But otherwise, for the colon, we don't routinely give it.
Thank you, Dr. Olivia. Over to the audience or the panel sitting there. Sir, any further questions before we go to our next step? Sir, we don't have any further questions on this.
Yeah.
So we can move to the
Requesting
next
panel
step.
members to please share your views. Maybe requesting Dr. Michael Oquelo to please share your views on the guideline algorithm.
Hello. No additional views on the guideline, but just to emphasize one part, Dr. Chitukas emphasized the clarity between upper GI and lower GI, and lower GI being insidious, but to have to take caution, especially with diverticular disease. Diverticular disease can have massive bleeding, and you can lose a patient in the shortest time possible. So that caution has to be there. Upper GI bleeding, you can have massive bleeding, but also in lower GI, especially with diverticular disease, you can have that massive bleeding. That's why history taking and having the capacity to stabilize the patient becomes something very important. Thank you.
Thank you. Can we have inputs from Dr. Victor?
Yeah, maybe just to say that the children and the adults will present similarly. The approaches are quite similar, but that maybe the ones that tend to occur is probably to a less extent. It's not as common as what we tend to see in the adults. The upper GI tends to occur probably because of some traumatic as opposed to probably pathological lesions in a more common way. For example, we may have the Mallory Weiss syndrome as the child vomits so much and causes injury to the lower part of the esophagus, and that could come with streaks of blood in the vomiters. But if it doesn't mean that the others may not occur, any other causes of, let's say, GI or esophageal varices, all those can occur in children, but probably to a much less extent than adults. Lower GI can also occur, similarly as Dr. Chitoka has mentioned. Sometimes we see diverticular and others, or depending on the age. If they are infants and they start getting some of those things, when you think about surgical conditions like intussusception, and that could be, in fact, an emergency that if you don't deal with it quickly, then the child may end up dying, may lose the child. So it's taking a good history. I want to emphasize what Dr. Chituka said earlier. Take a good history, examine the patient, consider the age of the child, an infant who is not, who is exclusively breastfeeding, then you have to think about structure abnormalities and try to investigate them extensively. We have challenges in the country at the moment with the scopes, how far you can go, how the infants sometimes you may not, they may not be widely available to be able to do a good endoscopy for very, very young ones. A few people can, but it's not very extensive. So if we can have as much of that as possible, and I would, maybe the surgeons will comment, or the what to come may add about this, the availability of what they can be able to do, but it's a bit of a challenge. The beauty about it is that for some of the conditions, for the older children, where you have the, let's say, diverticular, if you have it as being part of the problem, then the endoscopy could also be therapeutic at the same time. You go in, and that makes a very big change in the child's life. And but the key thing for some of these is that you consider the other things, because the bleeding may come later, but the child may have had poor growth, the child may have had weight loss. So don't wait for the bleeding, but consider all the other things that have happened along the way.
Thank you, Dr. Victor Musime. And may I now request to go on for the next algorithm, and that is GERD in adults. So may I request Dr. Vaine, Dr. Samuel Mutambo, along with the other panelists, to please share your views on the algorithm.
Good afternoon. Thank you very much. Today we're looking at the gastroesophageal reflux disease in adults as opposed to children. I want to emphasize that as the professor indicated earlier, is that acidipeptic disorders are quite common in Africa. The prevalence seems to be increasing, and I think it occurs in all parts of Uganda. So I think whoever is practicing, once you practice as a doctor, you're likely to come across patients who have complaints of epigastric pain or reflux or heartburn. So I think the most important thing is the symptoms, the presentation. As the earlier speakers have emphasized, history taking is very important. GERD is quite common. We used to think that it's quite rare, but as we do and more endoscopies, we have realized that it's quite common. So the most important thing is how does it present? What are the complaints? Most patients will have heartburn. Others will have retrosternal chest pain. Others will have difficulty in swallowing. But also others end up presenting in the ENT clinics before the ENT surgeons. And as other presenters will discuss, we have realized they can also happen in children. But now specifically for adults, is one must have a high index of suspicion, one must know the symptomatology, how does it present, any features related to heartburn, hoarse voice, some people have it. We have been emphasizing, we have been treating mainly, giving mainly PPIs. But I think also where treatment protocols have not been taken in consideration, emphasis on the lifestyle. Sometimes changing lifestyle alone may be enough to render an improvement. So anyway, if we go to the logarithms, the important thing is that after you are suspecting that the patient has GERD, is that particularly where you are not, you don't have facilities for endoscopy, is you can treat. Most of us give PPIs. Some patients may improve. So if there is an improvement or cessation of symptoms, is that you continue PPIs for another 2 weeks, and then you can taper the dose, and then you do long-term follow-up, and eventually you can withdraw that drug. But if there is no improvement, then you have to think about other measures, particularly endoscopy. If you are in a center where there is no endoscopy, they recommend that you may look at other possibilities that may present with those symptoms we have mentioned. However, if you are giving PPIs, it is recommended that you give a once daily dose of PPI. And if there is no response, then you can double the dose to twice a day. And again, if there is no improvement, then you can recommend the patient to go for endoscopy. If it's not available in your center, then you can send it to where it can be done. Whenever we have had patients with the positive H. pylori test, some patients, however, don't improve, and somebody continues treating without asking for an endoscopy. So in such a patient, where there's been no response, you have increased the dose to twice a day, still there is no improvement, please refer to a center where the endoscopy can be done. And if it is done, then you must look at whether the findings were normal or not abnormal. If they are normal, then you continue for another 2 weeks. If they are abnormal, then you can do other measures. You can think of other diagnoses. You can also have, you may be dealing with the complications of GERD, so that really calls for endoscopy where it is not available. Please refer to other centers. Thank you.
Thank you. Just add on to what Dr. Mutamba said and Professor Chama. GERD is a kind of, you can't make a diagnosis only by symptoms because they kind of mimic any other. If you have ulcers, they may be the same. If you have something like candidiasis in the esophagus, the same symptoms which Dr. Mutamba said. But there are some investigations you can do. One of them is, some of them are not easily accessible in our setting, but they are commonly done, like 24-hour pH. Just take you back, most of the time GERD is because acid comes out of the stomach and goes back into the esophagus. So that's why we call it reflux. weak.
Sorry, you're not quite audible. If you can put the mic little nearer to you.
Hello, hello.
Yeah, it's better. It's better. Thank you.
Yeah, as I was saying that the junction between the esophagus and and the the stomach is weak, so the acid has to refluxes back. So the most important issue is to see whether that, we call it a sphincter, is working. Is it weak? Is it strong? So there are some investigations we can do to determine the weakness. Two, to determine the amount of acid which goes back into the esophagus. And three, to determine the amount of damage done in the esophagus by this refluxing acid. So to determine whether the sphincter is really working well, there is a test we do. We put in a balloon into the esophagus and to see the pressures. There's a set pressure at which that sphincter closes, so that acid doesn't reflux back. And if the pressure is weak, is low, then there's a chance that acid is refluxing back. Then the amount of acid, there's also another test we can do. It is called 24-hour pH. We put in a pH meter, and the person moves around with it for 24 hours, and we see the pH in the esophagus. It should be alkaline if there is no reflux. But if there's reflux, that means it will become more acidic. Then we know that there is what? Acid refluxing back. And then to know the damage being caused by the reflux, that's when endoscopy comes in. Because we do endoscopy to see the extent of the acid damaging the esophagus. And that is very important, because one of the biggest problems with the untreated GERD is changing of is cancer developing. That the cells change, and we can get cancer of the esophagus because of untreated reflux. Now, the other issue we always do for endoscopy is to see if there is a physical damage in the diaphragm. If there's a physical damage in the diaphragm, the stomach tends to go into the chest. We call it a hiatus hernia. So that is also something we need to determine on what? On endoscopy. And for that reason, if someone is suspecting GERD, it is important to always go and check and see a medical doctor and see that these investigations are done. Not only to treat as if you're treating acid, you are just treating yourself from home, you are going over the counter treating yourself, yet you don't know whether this problem is there, because it's a very big problem which can lead to cancer if not managed well. Yeah, I will ask Dr. Picha to add some more about GERD. Thank you, Doctor.
Thank you very much.
Okay, thank you, Dr. Biani and Dr. Mutambo. I'm going to agree with you that reflux is very common because it's a physiological process whereby acid, actually in normal people, acid may reflux from the stomach into the esophagus. However, it's usually quickly cleared by esophageal peristalsis. However, if the acid is in contact with the esophageal mucosa very frequently, or the contact lasts so long, then it becomes a disease. So if someone maybe takes a heavy meal or drinks coffee, alcohol, and complains of heartburn for a few hours, that's not gastroesophageal reflux disease. But if this is very frequent, then that is disease. So symptoms, as Dr. Vianney said, may be typical esophageal symptoms or sometimes atypical symptoms, particularly in the ear, nose, and throat. So chronic dry cough, asthma, um, pharyngitis, sometimes sinusitis, or erosion of teeth could actually be a symptom of gastroesophageal reflux disease. So the most important part in the management of patients with reflux is actually history. So if you take a careful history, you're going to diagnose majority of the patients with reflux. And I want to emphasize this because endoscopy may actually be normal in someone with gastroesophageal reflux disease. So if someone has reflux but they don't have any erosions in the esophagus, the endoscopy will turn out normal. So a normal endoscopy doesn't rule out presence of gastroesophageal reflux disease. Now, whether you treat the patient based on symptoms or you want to go ahead and confirm on endoscopy really depends on how the patient presents. So if they have danger signs, for example, we know that long-standing gastroesophageal reflux can actually be complicated by adenocarcinoma of the esophagus, going through Barrett's esophagus and eventually adenocarcinoma. So you need to ask if the patient has any danger signs, bleeding, if they have difficulty in swallowing, then that patient is going to need urgent endoscopy. You're not going to try therapy without doing endoscopy because by the time you decide to do endoscopy, it could possibly be late. So if there are danger signs, endoscopy should be done urgently. If endoscopy is not available at your center, you have to refer. However, if there are no danger signs, then it's prudent that if the patient has the typical symptoms, you can diagnose GERD and give them a PPI trial for 6 to 8 weeks. And usually the patients would improve. And you give the PPI trial together with lifestyle modification that has already been described. If the patient doesn't improve after this, then you must do endoscopy because there could be something else, maybe non-peptic ulceration in the esophagus. Sometimes patients have extensive esophageal candidiasis that also presents with discomfort in the throat. I would also like to add that sometimes what patients think is reflux is actually non-reflux pain, particularly cardiac, chest pain, pleurisy, musculoskeletal pain. So if the symptoms persist, then you would also have to check out the heart, do an ECG echo, and review the history again. Thank you.
Thank you so very much, all the panelists here, especially Dr. Mutambo, Dr. Betty, and Dr. Varambe. My one question from our audience to any one of you who would like to answer to this: how to differentiate, between the GERD or whatever you call it, GERD, NERD, and the functional GERD. How to differentiate, functional or is there a real GERD or not? Are there any 2-3 pointers or are there any sign and symptom? This is a question from one of our audience.
Okay, thank you. So, so GERD, gastroesophageal reflux, could be erosive or non-erosive. So for you to tell whether it's erosive or not, you would have to do endoscopy. And at endoscopy, you may see some erosions in the esophagus, or in extensive reflux, you could see ulcerations in the esophagus. Now, it's not very easy to differentiate it from functional dyspepsia, but there are some symptoms that you could use to try and tease out whether the patient has true reflux or they have functional dyspepsia. For example, if you have the typical symptoms of regurgitation, someone actually gets food coming back effortlessly from the stomach into the esophagus, it's likely to be GERD. But if someone has atypical symptoms of retrosternal pain, bloating, and particularly if they also have some other symptoms of anxiety, because the functional GERD tends to come in patients with anxiety, if they have some challenges in life. But in that case, you would need to be sure that they don't have any danger signs. They wouldn't bleed, they wouldn't lose weight. So if the endoscopy is normal, before you call it functional dyspepsia, it would be good to do pH studies and actually confirm that there is no persistent exposure, reflux of acid, that the pH in the esophagus is high for the most part. And sometimes you would have to do manometry and rule out spasm in the esophagus. So that is in terms of trying to tease out. But in most cases, these patients will also present with anxiety symptoms and features elsewhere outside the gastrointestinal system.
Thank you, Dr. Betty. Dr. Betty, before I go to Dr. Mutambo on an opinion on this, I think what I generally use, especially to differentiate whether it's a functional or a real GERD, that history is very, very important. And what is that history? That history is if a patient comes middle of the night, sometime any spouse, any member of spouse of your companion, whether it's the husband or the wife. So it's very important to ask, is there any fight between you? Because many a times when husband goes back late at night or a wife which is late, they are sleeping and they feel, oh, you are avoiding me. So sometimes early in the morning you have a pain, epigastric pain, which is generally functional many of the times, and they want to check how much you love me. So I think that history part is very, very important first, and then you can go to, endoscopy and other part. We definitely can go for this, but I think that's a very, very important part. But though I'm talking it jokingly, but this is, I have experienced myself also, and when many of my colleagues, especially in the Eastern African part, many of them told me, they come across such things very, very, very frequently they come across. But again, so very nicely you have described. But Dr. Mutambo, any view on this same? How to differentiate is point number one. And second is question for myself. We do, as you said, pH metry can be done. So we do brow pH metry, but it's not regularly we do it. But with this, we put in a capsule inside the stomach, and then patient can move, and we can do. And there is another which is again invasive technique. We put in little catheter. So those are little less expensive. In that case, patient has to move around with another machine also. So I'm not sure which type of pH metry you do. So first question is again how to differentiate. Second is what sort of pH metry, if at all you are doing it, you do it in Uganda. Mutambo, Dr. Mutambo, or Dr. Betty, or Dr. Toronto, anybody want to answer?
We really, I don't know, we don't do pHs. We don't do pH, 24-hour pH. Hello? Yeah, we don't do 24-hour pH often, and personally, in my experience, I haven't seen one being done, so I can't comment on it. And but I think it would be a good one to use to differentiate between functional and non-functional GERD.
And also the history, you may need to get it from collateral sources which may not be readily available. The patient may not volunteer information to refer to functional GERD. May withhold the information, so it may be quite hard. Maybe it will be easier if you can get information from collateral sources, which may also not be readily available.
Yeah, thank you, doctor.
Yeah, yeah.
So with this, we'll move to the next algorithm of constipation and diarrhea. And may I request Dr. Luviasi Henry for for his opinion.
Yes, thank you very much, all the participants. As you know, with the recent change in lifestyle and diet in our environment, we are actually getting increased incidence of these diseases, constipation and diarrhea. Uh, Constipation is quite common, and it's what we always see in our consultation or in our places of practice. It's estimated around 10%, and that's average. But if you are in an urban setting, I think this prevalence is much higher than 10%. This is common in all age groups, the young and the old. And the diet, the lifestyle, all these are responsible for these symptoms. So when you are encountered with a patient with constipation, for example, you need, like any other GI symptoms, a good history taking or a thorough clinical evaluation is very important, because most of the causes of constipation, actually, as I've said, they are related to diet and lifestyle. And modification of these two factors is enough. So unless if constipation is associated with other symptoms, say there is associated abdominal pain, there is unexplained loss of blood, or there is associated anemia, weight loss, then you need also, in this case, that consider a colonoscopy, a total colonoscopy, so that you can evaluate or know that the cause of beyond diet and lifestyle. Ideally, in this algorithm, any patient with 50 years and above who has not been evaluated by a colonoscopy, who presents with constipation, and that's the person who is likely not to go beyond 3 motions in a week, or who's training for one reason or another, or he feels incomplete emptying of the bowel at every motion or in most of the motion. So that patient is categorized as constipated. So is 50 and above, and he has not had a recent colonoscopy in 1 year. This is the patient whom we will consider for a colonoscopy with constipation. And with diarrhea is also very common. I'll talk on the sides of the adults. Our colleagues in the pediatrics, they are more familiar with childhood diarrhea. But in adults, it's also common. And there are very many causes, as you know. This could be inflammatory, or it could be related to overuse of laxatives. Some of these are known laxatives which are bought over the counter due to people who go for them due to constipation. But in our environment, we are seeing so many people are using herbs with laxative activity. So people come with chronic or acute diarrhea. All these also need to be evaluated. And you need to explore if these symptoms are associated with other symptoms, so that you can really try to establish the primary cause and deal with it. So in our algorithms, which we've agreed on, so we will need to actually evaluate every patient who presents at least with 3 weeks symptoms, either of constipation or diarrhea, or the interchange of these symptoms needs to be evaluated very well for proper treatment. So, to conclude, many times I said in my opening statement that some of these patients, actually a very big percentage, do not need specific treatment. Just we need to look at their lifestyle. For example, inactivity. So if someone becomes active, we may deal with the constipation. Look at the diet, the travel history. Someone might have, traveled and changed the diet, and there is some bit of malabsorption and so on. So we need to evaluate all this before we go invasive to evaluate further the cause. So I'll ask my colleagues, I don't know whether Dr. Kalika is around to supplement. No, so if he's not around, any of my colleagues can add on that.
Thank you very much. I think in that case, Dr. Henry and Dr. Henry, yes, absolutely constipation and diarrhea. A lot of people and consider this as a very simple. It's nothing is happening, but actually it's very, very important. And many a times, a lot of patients I receive, which ultimately come out to be as an IBS patient, but they come very, very late. All these patients of IBS, whether it's IBS C or D, they come very late, and by then, it's too late to, specially treat them on this. But nonetheless, I see a lot of diarrhea patients, constipation. Generally, people try and handle at home itself, which, as you also mentioned, until unless it's very chronic and very frequent, they don't come to us. But thank you very much, Dr. Henry, for the wonderful algorithm, and I'm sure this is going to be very helpful. With this, Pushkar, we move on to our next session.
Yeah, thank you, Dr. Vipin Sethi. And with this, we'll move to obesity algorithm, wherein I'll request our panelists, Dr. Nakireka Susan and Dr. Francis Basimbe, to please take for the algorithm.
Hello. It's a pleasure to speak at this meeting. Obesity, like has been highlighted by Professor, is a growing problem, even in low and middle income countries like Uganda. And we are also seeing a growing problem of obesity among the children, especially in the urban centers. And most of the adults who are obese are women. And we have statistics from the 2014 NCD survey, which showed that 14% were overweight, while 4% were obese. And among the children under 5 years of age, the Uganda Demographic and Health Survey showed that 5% of the children under 5 were overweight and 3% obese. And it's a problem which is associated or contributes to non-communicable diseases like this we are discussing today, the gastroenterological disorders. We are seeing people coming in with GERD, like has been mentioned, fatty liver disease, and other gastroenterological conditions. So our approach to management of obesity Our first line of management we are recommending in our algorithm is lifestyle change. Most of the people who are obese, it's coming from a result of many factors, including genetics, but also the lifestyle. People are eating unhealthy, people eat high calorie foods, and we know that in the urban centers, people are physically inactive. And if you look at the children, these are children who are no longer physically active, and they eat what we call the junk foods, including the adults. So lifestyle change is key in management of obesity, but we need to keep in mind that lifestyle change is not a one-day thing. So when we receive people with obesity, our approach is to work with them to see that they change their lifestyle. And as a health worker, we need to keep the motivation going on. Some studies have showed that if you keep motivating, in one study, those who are motivated continued to change their lifestyle, especially in respect to weight loss. But as soon as the motivation went, people went back to their lifestyle, the previous lifestyles. So this is something we have to keep going on and on. The medical treatment of obesity includes several treatments, including we have some drugs we've mentioned. However, I need to inform that some of these drugs are quite expensive, and that's why we do not really want to initiate drug therapy in management of obesity unless we failed the lifestyle change. And we have people who push for the drugs without wanting to change their lifestyle. And this doesn't usually yield much change in the patients. So we encourage a lot of lifestyle change in our patients. One of the other contributors of obesity is hormonal changes, especially in women, pregnancy, and also postmenopausal women, but also poor sleep. We are seeing people not sleeping enough. It's a growing problem, especially some are not sleeping because they're on social media, but also because people are working late. So social media has taken over our sleep. And with sleep deprivation comes hormonal changes, but also the binge eating. So it's also something we need to look into, especially as we counsel patients with obesity. I'm going to ask my colleague to talk about the surgical interventions available in Uganda in management of obesity. Thank you.
Thank you very much. Thank you, Doctor, for that elaboration. I'm just going to add a few aspects to what you have mentioned. I think it's not overemphasizing when we say that this is becoming a big epidemic. In Africa, we are seeing increasingly many people that are presenting with these issues. The association that you've mentioned, I think we can also emphasize more on that, especially the aspects of obesity and reflux, obesity and malignancies, especially the GI malignancies, and these associations have been established in many studies done. Still to reemphasize, before I go to the options we have surgically, what you've said is the role of lifestyle changes that need to be done, especially these changes are the ones that are going to ensure that once these people lose weight, they do not regain the weight. In fact, many studies have been done where if people were prescribed surgery without emphasizing these lifestyle changes, many of them regained their pre-surgery weight within 18 months. So that literally shows that ensuring that you take a good history and give the right psychological support, the psychosocial support, and then they do the lifestyle changes that are necessary. The diet, the exercise is what is going to maintain the weight loss and not necessarily the surgery. But still to continue on that, within the management, there are several aspects, and like you've mentioned, lifestyle, medical, exercise, psychology, because many times by the time these patients present, there's a lot of social issues that have happened, and that in itself can cause, again, factors that are going to make sure that weight loss becomes an issue. In surgery, currently, we are able to do things like sleeve gastrectomies, Roux-en-Y gastric bypass in this country, but still going back to re-emphasizing that, because I know many people here, many surgeons who are doing GI. We've had patients who walk in and for them their emphasis is, I want to lose weight, and is there something that you can do? And they are looking for a quick solution, maybe do a gastrectomy and then the weight goes. And yet, like I've mentioned, that many times does not permanently solve the issue. It's only when many of these other things have been addressed. In fact, the percentage that may reach that point is a very small. If you start with 100 patients who have obesity challenges, those that you may end up needing to do surgery on should be probably about 5% of that number. The majority, you should be able to solve these issues to get to the required weight by using other methods. Thank you.
Thank you very much, Dr. Francis and Dr. Susan. As you very rightly mentioned, obesity, which is which is an epidemic today, and it really needs to be controlled. But I take one clue from Professor Oshama's presentation, wherein he mentioned one of the a trial which was a questionnaire and all that, which happened, and he very clearly said, this obesity is an epidemic, and especially for the Africans who are going out, who has gone out, they tend to become very obese. However, those who are still in Africa, they still tend to be less obese. So I think, Professor Achama, the take-home message from that trial I take is, don't go to Netherlands. Otherwise, you will become obese. This is one trial which Professor Achama mentioned. Well, the jokes apart on this, but obviously obesity is an epidemic, and we need to really control. And the best part is, the lifestyle management, and then one should go for surgery. So I have seen many of my colleagues, my friends, and who are going for surgery, and my friends who are operating upon them, a lot of bariatric or gastric bypass surgery. So until unless it's a mix of surgery as well as lifestyle modification, nothing will work. As you rightly said, they very fastly they approach to the pre-surgical, the weight, whatever they have lost, they're going to gain very quickly. So it has to be a mix of both. You go for surgery, but then lifestyle management, and most importantly, don't go to Netherlands. Otherwise, all Africans will become little obese. With this, I will request Pushkar to move to the next section, please.
Yeah, as we move to the next section, I should also say that, because I think the rate of reflux, the rate of relapse in obesity should be high, even in those people who undergo surgery. And really, the lifestyle changes will be the major point to really take in order that we don't get these persons, because I've seen people very obese and now the knees can no longer hold the weight, and then and you're telling them you run and they can't run because I told one that if you are found running, people may ask you who is pushing you from behind, who is chasing you, and so so it is a tough thing, but somehow I think the lifestyle modifications are very important. Thank you.
Thank you, Professor. May I request the panel members to share your feedback?
Thank you. My name is Dr. Kagwa Sol. Thank you for the, I want to comment about a few things about obesity. One is motivation versus stigma. When we are counseling these patients about motivation to exercise, to eat healthy, we need to use statements that do not really stigmatize them. Otherwise, they lose the motivation. Number two, we need to counsel them about diet using available options. Many of us read Western books and then we tell them to eat oats and what, yet there are many cheaper things available for us. Number three is we need to decide about the need for surgery early before comorbidities set in. As Professor already said, you tell them to do exercise, they already have arthritis, they cannot, and they already have DM and cardiovascular diseases. So we need to identify those who will benefit from the surgery early. Patients who have a BMI already above 25, we don't need to wait much as long as we know that they will stick to the lifestyle changes. Losing the weight after surgery actually motivates them thereafter to maintain a lifestyle which won't allow them to go back if the counseling is done early enough and well. Number four, we need a multimodality involvement. We can't carry on everything as the doctors. We need to involve the nutritionist. We need to involve the physical therapist to guide them through exercises, because it seems that doctors, the only exercises they know is the aerobics and running. And these people can't run, can't do any of those things. So we need the professionals, the physical therapists to start them early. And number five, we need to involve families, especially in young adolescent obese patients or young patients. Usually the lifestyle problems stem from the family. And until you involve all the family members, you actually don't see much change. Thank you very much.
Thank you very much, Doctor, for highlighting very important healthy lifestyle points. And with this, we'll move forward to very important algorithm for children, and that is basically pediatric constipation, GERD in children, recurrent abdominal pain in children. So for which I'll request our panel members, Dr. Sabrina Kitaka, Professor Victor Muziame, and Dr. Loren, to please initiate the algorithm. Requesting Dr. Sabrina, please lead the algorithm. Thank you.
Sabrina, you're not audible. Oh, I think your audio is switched off.
Due to public demand, I'm going to say exactly what I said before. I was feeling a little marginalized when the adult physicians were going on and on and on about adult issues. And yet, in fact, we know that children are the most populous in our country. 30% of our population is less than 19 years. So it's important that all of you listen attentively as we go through this algorithm. So in terms of constipation, you've already had the definition If a person has less than 3 motions or bowel movements in less than a week, then they are constipated. And if they are straining to pass stool, they are constipated. I know that many pediatricians here, Professor Msime, Dr. Lorraine, and others on the call, many of us have been sent pictures of stool samples by parents. And sometimes you're in the middle of having a meal and poop, your WhatsApp shows up and there's a fecal sample in the photograph. In this algorithm, we've been intentional about sharing the Bristol stool chart, which describes the stool types. So please look at it because you could be the next person receiving a cool picture from a mother. We know that many babies have functional constipation. Unfortunately, a lot of the constipation that happens in children is actually temporary. However, it's important for you to always take a good history. Taking a good history will save you from getting repeated calls or repeated visits from a mother. And we also know that as the child grows older, it can be a challenge of toilet training, etc. When do we get concerned? We get concerned when a child has constipation and excessive abdominal pain, a child has constipation and blood in the stool, and it's at that time that you need to refer to our colleagues who are the surgeons. In addition, children may not talk, and they're just there struggling with constipation. But a child who is born and doesn't pass a stool within 48 hours is an emergency. It could be that the hospital where they delivered from did not examine that baby and they have an imperforate anus, or they have a condition called Hirschsprung's disease, and they really, really need to see a surgeon. So without taking all the 8 minutes, I want to donate them back to my colleagues because we have other things to discuss. As you examine a patient who comes in with constipation, look at them in totality. Take a good history. How are they feeding? What are they feeding on? Are they gaining weight? Are they not gaining weight? Do they have a pendulous abdomen? And finally, before you say that you've examined a patient for constipation, like Dr. Olivia Chitoka mentioned, please make a digital exam. And then the treatment could be medical or surgical. But every one of us in this room knows that even as we are discussing the World Digestive Health Day, if you've not made a poop in the last 3 days, please seek medical advice. Thank you. I'll hand over to Professor Musime.
Thank you very much, Dr. Chitaka. I will talk briefly about GAD. Our adult colleagues explained very well what the circumstances are. I just want to emphasize the aspect of age again. We still look at the children in two categories, the infants and those that are older. The infants, because of the immaturity of the gastroesophageal sphincter, GERD or reflux per se, happens quite commonly. And as the infant grows, it can stop. So looking at it, and so then the rushing to give medications may not be warranted. So that's very, very important because many of them, as they grow, they tend to outgrow the reflux. Then the other thing that is important is that they may not express the symptoms as you know them, but you just see a child who is not thriving, not gaining weight, not feeding well, and that may be the early pointers that there may be reflux in this infant. The older children, as they become older and older, they become much like the adults. They may start complaining about pain, they start complaining about all the other issues that we see among the adults. So the approaches to investigations and management are also dependent on the age. The history is very, very important. The meals they take are very important, and even the management approaches. For the infants, sometimes it may just may just be something as simple as changing the texture of the milk or the consistency of the milk. If you make it a little thicker, it may not reflux as easily as something very liquid for this immature sphincter. Then the others, as they grow older, they sometimes require medications, and you may end up giving them PPIs for relief. But it's important to take it step by step without rushing to the PPIs. The history is very, very important, and monitoring growth and weight are very, very important as you do this, because they may be the early pointers before you get overt chest pain or retrosternal pain. I'll hand over to Dr. Lorraine to talk about recurrent abdominal pain.
Thank you, Professor Musime. So I'll be talking about recurrent abdominal pain. And this is something we all have met either in our homes or in our clinics. And many times we want to take it lightly and say ignore it. But I like that in the guidelines, the emphasis is on taking it seriously. You actually need to figure out, is there actually a physical problem in this case? And I like that the approach in the guidelines is rational. You're not going to over-investigate this child, but you're also going to take their concerns seriously. Important and top of the list is a detailed history. In many of the cases I've seen of recurrent abdominal pain, the problem is in the home. So a history is very important. What's going on in the home? Have there been changes? And that's emphasized in these guidelines. You also need to do a very detailed examination, because this is not something you want to brush up. And there are a percentage of children who have recurrent abdominal pain who go on to develop malignancies. So it's not something you just want to brush over. Also important to note are the investigations that are recommended. And many times in our setting, there's this need to investigate and investigate. I mean, one time I saw a child who had gone as far as Nairobi and done a PET scan, and it was all from this recurrent abdominal pain. So it's very important, one, to be practical, to take a rational approach, and also to reiterate that family is very important. So if you don't involve the family, then you're going to get lots of problems. A colleague of mine had a case recently where the mother had separated and had told the child that, oh, your father moved away. And this child developed recurrent abdominal pain because of that uncertainty. So this is one of those areas where the social history is important and dealing with the social circumstances is important, but also determining whether there's actually a physical condition or a physical problem that needs to be dealt with. Thank you.
Thank you very much, Dr. Lorraine, and all the panelists here. So, Dr. Sabrina, as you very rightly mentioned, constipation, which is when it comes to adults, maybe they would like to manage themselves most of the time, but when it comes to infants and children, I think it's very important. Infant neonates within 48 hours, it's an emergency if they don't pass, and if if you don't have a 3 or less than 3 stools in a week, that's another emergency, and you need to go and visit your doctors, which is very rightly you said. So I think when it comes to children and infants, most two important problems which we have discussed is one is this constipation, which is very, very important, and other is very important is abdominal pain, which Dr. Lorraine very rightly mentioned. Taking a lead from them, Dr. Sabrina, this question to you. An abdominal pain, and how frequently do you come across GERD, or I would say mostly it is GERD or it is only GER when it comes to infants or children. If you come across that, what should be the percentage, and how do you manage it? I hope my question is clear, Dr. Sabrina.
So thank you so much. As we heard, GERD is a reflux when you have an immature esophageal sphincter, And like you heard from the adults discussing, it can be functional dyspepsia or it can be a disease actually. And when children present with GERD, it can start from an early age and it can start right from, in the neonatal period. Sometimes it's, I want to say behavioral modification, encouraging mom to burp the baby, not putting the baby to sleep very quickly. And also we could add dietary modification, behavior change, but also ensuring that we may give proton pump inhibitors in some cases and histamine H2 antagonists because medical treatment actually helps. Sometimes the children present with vomiting and they may develop allergies towards the acid that's refluxing. And these are children who will present with a chronic cough or discomfort. So you need to intervene at one point and not just keep telling them about behavioral modification. But I'd be happy for Victor to add on.
I think you've brought out the issues really, but if I had your question well, the approach is really starting off right from the history, the examination, you follow up, you take time, and majority would respond to non-pharmacological approaches. But for there are some, like Sabrina has emphasized, there are some where you will require medication, and those are very important to follow up on a long time. And you may require having endoscopy. For the older ones now, we are able to do them, but there are some where you may not be able to do that. So it's important that you work with the family.
Dr. Victor, would you like to add a bit to it, or any of you, I mean, Dr. Lorraine, Dr. Sabrina, how clinically, if a small child comes to you, whether it's a 2-year, 3-year, 4-year child, and crying, having a lot of abdominal pain, so, and you want to diagnose, maybe clinically at that moment of time, is there any possibility to say this is a physiological gastroesophageal reflux, or it's actually a GERD? Clinically, or if you want to do some investigation at that moment of time, I'm not going to the endoscopy level.
Yeah.
If you would like to comment on this.
Yes, I'd like to comment. There are risk factors for GERD. One of them is a history of in the family that there's GERD, but also in children who are born preterm and those who have neurological deficits. We also know that some children with various disorders like Down syndrome may be prone to getting GERD more than others. So again, just to emphasize, it's the history. It's individualizing your diagnosis and not generalizing it.
Thank you, Dr. Sabrina. I think the overall the points what is coming, with all the algorithm has been a lot of this discussion. The most important part again and again, even though so many robots or technology comes, I think the history, which is very, very important, the clinical examination, which is very, very important, and knowing your patient, that's I think very, very important. So before we move to next agenda item, you'll have to give me 5 minutes. I would just like to share my screen with all of you, and since a lot of these diseases and all, we've been talking about a lot of PPI. So I would just like to share a few things with you on my screen. You will have to be with me for 5 minutes, and then I'll go to the general discussion which we want to have with all this algorithm. So again, coming back to same patient presence, whether it's in emergency or it comes to your OPD, and lot of gastric problems. So we are only talking about gastric problems. This can be a differential diagnosis, can be anything. Now I'm not differentiating between children, adults, and small adults. So the gastric problems, as we understand, and we try putting all those gastric problems in this booklet, which can be upper GI bleed and the lower GI bleed, and upper GI bleed maybe because of peptic ulcer. When it comes to peptic ulcer, you come across more of urinary, less of gastric ulcer, constipation and diarrhea in adults, though it is treated as a very general condition, but I'm sure this creates a lot of problems. A lot of patients come out with irritable bowel syndrome and all. Obesity, which is another epidemic which is coming up and all that. We need to treat that also. children, don't take it lightly. I mean, they're going to be really, really, very painful. They really have to take care of our children because that's the future of any country or any generation. But when it comes to this, this our gastrointestinal symptom is just like a snake. And if you look at that way, a lot of things are happening inside this snake. I won't take you, all those diseases which you have already discussed. I only take you to, since most of these diseases, we'll be using a lot of PPI. We are talking about it, but any disease, if we have to come, and we all come to a sensor, the diagnosis is mainly history, very important. Knowing your patient, your relative, the genetic part of it, and what all they need, what sort of lifestyle management. Then it comes to clinical examination. Then the third important is risk stratification, then endo or colonoscopy, and then we come to medical management or the surgical management. So these are some of the diagnostic point of it, and these are a very simple point. Wherever you go, you need to do either a PPI or an H2R. I'll give you a very short story. During my registrarship, one of my professor, when we used to be in inpatient or ward, every second patient will write a PPI. So at that moment of time, we were resident, and we used to be very amazed that this professor, why is he writing either S2R or PPI to each and every patient, which we that time never realized, but we realized, when we grew up and we started our own practice, that it's always better to give either S2R or PPI. Nowadays we give a PPI molecule or a combination of this, because when a patient is, it's an IT or a patient who comes to you as a tertiary care center, mostly they have had a lot of stress, lot of different types of medication and all, and they are bound to have, GERD or gastritis or heartburn or acidity. There's so many names we call it to you, right? So they have to have it. And I started using the same practice. But when it comes to PPI, there's so many, I'm sure you all know, first generation, second generation, various PPIs are available. Now the next question comes to my mind is, which one I should use. So I am an emergency critical care specialist, and mostly patient, what I see, it comes in emergency. So many a time these patients, either they are accompanied by their relatives or they don't accompanied by their relatives. Either they are conscious or they are unconscious or subconscious mind. So it is very difficult to take history. However, I can do a clinical examination, but taking history is very, very difficult at times. And sometimes you are so much in hurry, you're following ABCD, patient is in emergency and critical, so you need to give certain medications. So I found a way to use, which PPI should I be using, right? And this was basically on clinical evidences and pharmacological parameters. So first was pharmacological parameters. And some of these parameters, I started using it, and then I take you one by one with all these 4, 5, 6 parameters. Let's take one by one. So one important parameter which I said is, based on evidence of recent clinical trials, is the PK value. So I dig out and find out, pharmacodynamic and PK parameters of this. That various PPI, when we looked at PPI, what is important for our patient is, the fast. It has to be very, very fast, and it has to be consistent. So when we look, whether it's ribitrazole, omeprazole, esomeprazole, benzodiazepine, the relative PKA for these PPI we found ribitrazole is one of the best PKA. That means it is acid stable. It accumulates in parietal cells more than any other PPI, and the activation rates are very, very fast. And that's what we want. Our patient, when comes to us, it is very important that we give them relief without any hesitation. And fastest relief, this is what everybody would want. And based on these PK parameters, which are very well known to all of you, are only reiterating those things, right? Which was published somewhere in 1999, very early days, and it stands to even today. So that's very important. The second parameter is activation rate. Again, activation rate, why I'm saying, because when there is a gastritis or there is a peptic ulcer, the pH automatically drops because there is a lot of acid inside the stomach. And every PPI will act different at a different pH. If you look for PPI who is acting at a pH of 1.2 would be different activation, and 5.1 it is going to be different. So if you look, this graph which very clearly says, ribitrazole is one which activates all the proton pump, activates, it goes into the parietal cells, and the moment it enters in the parietal cell, it starts activation within 7 to 8 minutes. That means it will give you a very fast activation and your patient will get a very good relief. See, ultimately, whatever disease you say, whether it's upper GI disease, it's GERD, peptic ulcer, esophageal, gastritis, recurrent, and all, ultimate important is the bleeders will not stop until unless you bring a pH of more than 5.1, which is the magic number, or pH is 6, which the Professor Ochano also in his talk earlier said, the more than 6, it has to be alkaline. And many of you reiterate it. You know, why we do pH or the kinetics also we do it. We do a lot of bio-pH manipulation. It takes very quick for regular zone to act on this, while others take a lot of time. So everybody is affected, but all PPIs take different times in this. So regular seem to be the fastest in one. This is a very important and wonderful diagram which I use in my various CMAs across the globe when I do it, because drug-drug interaction, I'm sure most of you have come across the drug-drug interaction. Then there was about 2, 3, 4 years ago, there was a lot of debate used for PPI with especially clopidogrel in cardiac patients who are on long-term clopidogrel now. And there the debate started. And that debate was mainly because both the drugs, the metabolism is through liver, through CYP2C19 route. Now, all these PPIs mainly metabolism is absolutely right through liver and through these enzymes of CYP, 2C19, and 3A4. However, when it comes to letrozole, the 80 to 90% metabolism is not through liver but through a non-enzymatic path. And when I say this, I say this is one of the smartest PPI, because everybody, when there is a fire and everybody is running out through the door, this PPI runs out through the window. So that's the smartness of this. But how do I use in my clinical practice this thing? Let's assume a lot of patients when they come to you either in OPD or especially in emergency or in ICU, and when you don't know much about them, these patients are on so many medications. And when there are so many medications, I remember my medical college time and pharmacology used to be very boring for me. I never used to read much about it, right? So then I realized the importance. So in this case, since most of these medications will metabolize through liver, while letrozole metabolize through non-enzymatic pathway, the chance of drug-drug interactions are very, very minimal or there is no interaction. That means I don't have to think much in emergency practice. I simply has to give a bolus of PPI, which is regular. So this is how these PKPD parameters. When I read a lot of it, I started using in my clinical practice. So one most important thing is it has to be fast, very fast. It should be stable in whether the pH is 1.3 or 5.1. Third is drug-drug interaction, which generally gives us a lot of trouble. So efficacy of either the drug will alter because of this. And last, fourth most important thing is whether I am in India or I am in Africa or I am in, Egypt or Israel, the drug should act same way. Whether I have done a clinical trial here or I have done a clinical trial in Uganda, it doesn't matter. So in that case, as you all know, there are people who are poor metabolizers, they will metabolize very poorly, and there are some who will metabolize, very extensively. So we did track on this, and we said if the ratio between these two is minimal, that means there is a predictability. So again, it came out to be that simply based on PKPD, and this is what we call genetic polymorphism. The ratio of AUC, area under curve, or extensive metabolizer as well as poor metabolizer is very minimal. So again, the predictability part is there with agriculture. So you use it here or use it anywhere at every age group or every race, it's going to be same. And next important point is as some of you mentioned, you start febitazole in GERD or any PPI in GERD as a once a day. And once a day, how this concept comes is we understand and we feel that it will give a 24-hour acid suppression. So we using Bravo pH monitoring, we did that and we found that letrozole was the one over a period of 24 hours. The average pH was more than 3.4, while others were having much less, wherein placebo was only 1.2. So placebo also sometimes acts on this. And last but not the least is, this is twice is all. This is the way I use in my practice using PKPD parameters. However, I think important for you is before you using any PPI, is use PPI that help achieve the desired intragastric pH of more than 6 at a faster rate. Second is 24 hours because NAD is going to trouble your device. The patient daytime will go bad, but at the night will say, "Oh, doc, your medicine is not working." So 24-hour acid separation is also very very important. And 24 hours, when I say that means NAD, nocturnal acid breakthrough, which is a pain, really a pain. This should help. So understand your PPI and use that. Obviously, with the clinical trial, safety should be established. That's a prime role, and efficacy is anyway. Without efficacy, nothing works in this. While saying so, I understand Verilog is one such Remiprazole which is innovated by Kevila and it is patented product in various countries. And I'm sure you are using this. So this I just wanted to share with you very quickly, my experience on this. Uh, with this, I would like a comment from your side. But before a comment from your side, I go back to Professor Achama. And Professor Achama, I take a lead from your presentation there, and just want to have one clarity or maybe a question on this. You mentioned two trials, Professor Achama. The one trial was one study which happened in Canada in 2001, which was about 90 or 100 patients, where you said the GERD or H. pylori. H. pylori is almost 80% of these patients found to be H. pylori positive. However, in 2009, there was another study which happened, and there, the H. pylori patients found to be very, very less. How would you want to react on this? One answer may be, either H. pylori, it's coming down. People are more aware, well aware of this, or H. pylori itself is coming down. Because earlier, 2001 says 80%, however, 2009 it says about a very less number, which is maybe about 50s. Professor Achama, over to you, and
Yeah.
then we can discuss on various other aspects.
Thank you. So I think the two studies, one used antibody test. The one of 2001 was the antibody test, and the one in 2009 to 10 it was using stool antigen. So that probably was the main reason that we could see the difference.
So you want to say because of different parameters used, the outcome seems to be different. However, still H. pylori numbers would be 80 or 70 or 80%. This is what Professor Chang.
I don't know what it is right now, but yes, possibly we still have high levels of H. pylori infection in the country because we are seeing these every time in those who are testing for H. pylori. And there's so many patients who are coming in. In fact, one insurance company told me that the accountant told me 70 to 80% of all claims from their company is for peptic ulcer disease, and this is diagnosis being made on H. pylori. So I still believe we have a lot of H. pylori, of course, in this country.
So may I go to other panelists if anybody wants to say any points on this H. pylori, since these two studies different parameters were used and there are different numbers. So what would be the date as per your experience? If any of the panelists, offline or online, would like to comment on this.
Making a comment. They are shying away.
They're shying away. They're shying away. So I need to name. So I'm talking about adult. I was talking about adult. Let me go to our friends who deals with the children. So they can't shy away. Yes, Dr. Sabrina, I see you. I can see you. You can't shy away. What do you have to say? What do you think? When you say 19 and less, so I understand 19 and below all are children, and 49 and above are also children. So where would you like to comment? 19 or below, or 49 and above?
Maybe
So I repeat, Dr. Sabrina. My question is, H. pylori. What do you think? H. pylori, how prevalent it is, and what would be the incidence in Uganda?
Let me first talk. I hope she won't shy away after this. But we are we are still seeing, children now when children go with abdominal pain, and virtually everybody, including the ones who are 2 years, 3 years, they are being tested for H. pylori and they are positive, and so they are being treated for peptic ulcer disease in quote, and then treated again and again, and then eventually they end up with some of us, and most of the abdominal pain is actually functional, like was mentioned before, and so you start the other aspect of the treatment, and it got worse after the COVID 19 outbreak. I think most of us saw this, that many children were being brought back home from schools because of abdominal pain. I don't know whether it was an isolated event on my part, but every time you would see 2, 3, 4 children a day coming back from schools. They have been treated. They have been treated for H. pylori related, abdominal pain, but they're not responding. So most of it was happening to me because I think children had gotten used to staying at home, and so they didn't want to go back to school. And actually, some of them confessed after some counseling that I don't want to stay in that boarding school anymore. I don't want to go to the school anymore. And so I think we still have H. pylori for sure, even in children. They are testing positive. But not all the abdominal pains are being caused by H. pylori related diseases. So the H. pylori is, in most cases, a bystander. Thank you. Sabrina, maybe.
Sadly, someone keeps jamming this microphone when it comes to children, but anyway. So I agree with Professor Ochama, and I just wanted to say that the treatment of H. pylori is a triple pack, which includes antibiotics. And we need to rationally give antibiotics because before we know it, we won't have any other antibiotics to give to our patients. And like Professor Ochama said earlier, the treatment for H. pylori may inadvertently cause gastroesophageal reflux disease. So we need to be extremely careful before we say it's God. I wanted to say that during the COVID period, people were imbibing a lot of concoctions, including ginger, lemon. Somebody even coined a name for it, the BCG concoction, something like that, which was extremely dangerous. Not the BCG, but the concoction. So that's all I wanted to say. Thank you.
But Sabrina, do you recommend any concoction for adults along with ginger, lemon, and
Of
would
course,
you like to add some more to it?
adults are the ones who take most of the concoctions, as you may know.
Yeah, absolutely true. Absolutely. Dr. Victor, would you like to add something to it?
Just to emphasize the point of the psychodynamic nature of the pain, there are lots of children that have undergone so many investigations, multiple endoscopies, and all they need is really psychotherapy. So there are some whom we have managed successfully by referring them to clinical psychologists. For one, even we saved them a trip. They were booked to go to Nairobi for a PET scan or something like that. But just psychotherapy helped. So I think it's very important to work with the family. I think this has been emphasized a lot. It's very important that we do that, but we shouldn't dismiss everything as psychogenic. There are some which need further investigations and management.
Thank you very much. And I take another lead from Professor Chama's presentation, which is about FGID, wherein he said, there was a global questionnaire was given and 40% have FGID. So, Professor Chama, I will not, take more time and not take it through. Otherwise, I understand. I don't want to come between, you all and your lunch. Otherwise, there will be a lot of FGID. We all can have some pain and all. I would like to close it here. And Professor Chama, over to you if you would like to, take some more questions or something. But from my side, I think it's mostly you. I have a couple of things, to discuss, but I don't want to come into you and your lunch. So over to the forum, Professor Chama.
Thank you very much, Vipin, for staying with us across all this time to attend this meeting, a very important meeting. I think to talk about the take-home messages, I think the take-home messages are already sunk in these people who are attending both online and also physically here. About upper GI bleed, about GI bleed generally, upper GI, I think, both of them, stabilization is very important. For lower GI, stick your finger in. That is the message. Stick your finger in to be sure you know what is happening. Otherwise, sometimes it is very embarrassing that somebody has a lower GI. One time I was called to see a patient, and on a private wing, and I go there and I say, okay, let me see what is happening. And the patient had this GI, lower GI bleed, which was very disturbing. And while I was trying to stick my finger in, the answer came out. Huge hemorrhoids, bleeding. And I said, okay, we found it. We started acting immediately. And then, of course, God, I think the lifestyle changes, PPIs, about obesity, we have talked about the nutritional and again lifestyle changes, nutritional support. People with the GAD, with GAD actually, with obesity, we really need to be, understanding, like he told us. I think sometimes we overhype the whole thing and tell about the food they should eat. And then you mention a long list of food that is found in supermarkets, and many of these people are not able to afford the food. And so you start wondering, that's not being very sensitive to the surroundings. Somebody came to my home. He came with the two sisters, a man and the two ladies, and they had gone to a nutritionist. And then they went back to my home, and they said they went to the nutritionist. They were given a long list of things, the oat, the what, all those things from the supermarket. So he told me, let me first eat this one for today, and then I will start the other one tomorrow. Certainly, it was not, it was not possible. This is a person who is going back to Teso land, deep in the villages, and you're telling the person to avoid some of those. So it doesn't work as well. In children, really, we have to investigate them and be sure we are not dealing with a physical illness. There are many. There was a child who traveled 200 kilometers with the mother and told us that she had not passed stool for 4 months. 4 months. And I said, okay, I look at this girl. She's looking very nice, young, very active. Any abdominal pain? Nothing. Any abdominal discomfort? No, but no going to toilet. And then I decided to examine this lady. Nothing. The abdomen is soft. The lady has not had no signs of loss of weight. She's plump and all this. So I told the mother, so there is a problem. The problem here. So somebody said, give her a potty and we see what is going to happen. So the girl simply laughed at the mother, and that was the end of the story. So some of them, I think she didn't know what to say to the mother. She could have used more sophisticated language, like abdominal pain, which the mother probably would not be able to tell whether it's actually there or not. But this particular one, no, it will not work. So, having said that, I think I will give this to you. But before I give to him, I want to thank all of you. I want to thank all of you for coming here, for attending this meeting. On behalf of Uganda Gastroenterology Society, ably represented here by by Her Excellency, the Vice President, Dr. Olivia Chituka, and represented by the Treasurer, Dr. Betty Apicha, and the writer, Emmanuel Dr. Seremba, all here, and all of you from the different sections, the pediatricians, the surgeons, and and every other person who is here. People who participated actively in writing this book. I told you this book took close to 3 years, 2.5 years, putting it together. During the COVID time, we were very busy having conference calls on this, and eventually it has reached here. It was the effort of every person who is here, and I want to thank also those who are online for really attending this meeting. We still have a few things to do, and then I think people are hungry. We are going to get gastric erosions, so we need to have these things completed. It won't take us long now from now on. Thanks.
Thank you very much, Professor Chama. I think before Pushkar, you go live there, I would like to thank each one of you, especially the panelists who have been bearing with us for last 2 years. I think as Professor Chama said, it took us a lot of time, but everybody put in a lot of effort. And thank you so very much from my side on behalf of the entire team there. To each one of you who are sitting there or who are online. Thank you once again very much. You carry on, please, Pushkar. Thank you so very much.
Thank you, Dr. Vipin, for nicely moderating the entire session, sharing your insights. And I must thank Professor Ochama and entire panelists for listening very patiently. Now, before going into any other proceedings, may I request Professor Ochama sir and all the panelists to please come in front for the unveiling of Uganda Gastro Consensus Guideline Booklet. Give a big round, please. Give a big round, please. I'll request all the panelists to please come on the stage. This is a remarkable moment. This is a remarkable moment. Let me admit, and the entire panelists have worked for more than 2.5 years to make the consensus guideline come live. So may I request all the panelists and may I request my colleague, Mr. Ajay, to just bring the books to unveil. So give a big hand, guys. Give a big hand, guys, for unveiling of the first book. So may I request all the panelists to just showcase the book. Just showcase the book. May I also request the technical team. I'll also request Mr. Ajay to join in. Mr. Ajay to join in. Yeah, 1 second, sir. So I'll request the panelists to please join in. also, I'll request Mr. Ajay or one of the panelists to please be here to balance the entire picture. So, guys, all the doctors requesting you to please give a big round of applause for Uganda Consensus booklet launch. So I'll request to take a small video, and I'll request the entire audience to please give a big round of applause for all the panel members of Uganda Gastro Society. Once again, we sincerely thank all the panel members for sparing your valuable time. And today we have came at a landmark. From today, our journey, next journey will continue. We'll be putting all the effort to make the booklet popularized to all the corners of the country, and we'll seek your timely guidance to make the effort come into the existence. We have, as Cadila Pharmaceuticals, we have already planned to have more than 2,000 booklets to be planned across the country, and we'll seek your timely inputs to make it a grand success. With this, before we disperse for lunch, a small note from our president.
Thank you very much, Pushka. I think this has been a very hard work. All this time, it was a heavy one, as heavy as a metallic cross. But even the metallic cross can be carried. It was carried up to today, and I want to really thank Kadila to have helped us with all the facilitations that we needed to make sure that this book comes to fruition. And here it is. We have the book. This book is for every person and every clinician to actually have. We shall also try to have we shall send it also out on various forums so that people can actually have the soft copy and they can have these books with them during for a quick consultation. Those who will read it, it is basically in algorithm format. It is not a full writing. This is very easy. You say, when I see this, then I do this. When I see this, I go here. When I see this, I go here. So to make it easy for clinicians, I want to thank you again. And so I want to declare that this book is now launched officially in the country.
Mr. Pushkar, you are not audible to online viewers. So there are many online viewers still. You're not audible.
Yeah. So thank you very much, the entire panel members of UGES, Dr. Vipin Sethi, Cadila team, including Mr. Ajay, Dr. Hitesh Mashru, who has been very instrumental in preparing the entire algorithm, entire Cadila Kampala team, and our technical team. I would like to thank them all. Along with this, I'll sincerely thank all the online doctors who have been listening us the entire algorithm launch from more than 2.5 hours for patiently listening. Also would like to thank Cadila core team, Mr. Raman Khepar, Global Marketing Head, Mr. Tushar Huda, East Africa Head, Dr. P.K. Rajput, Africa Head, for supporting all across for making this event possible. We again request all the online doctors, please join us in our continuous medical education program, which we are going to launch. And we will be arranging the e-learning modules for each one of you. For today's session, all the virtual participants will be getting online certificate, and that has been already organized. So thank you once again. And before we close, I'll hand over to Mr. Ajay for his concluding remark.
Good afternoon once again. I'd like to say thanks to Dr. Professor Ochama, who is leading since 2019 for this booklet, and all the panel members who have contributed a lot. I can name the few: Dr. Sabrina, Dr. Louis C. Henry, Dr. Basimbe, Dr. Seremba, and Dr. Aquilo Michael, Dr. Vianney, Dr. Victor. Thanks for coming and making a successful program for the day. Thank you.
Thank you very much. With this, we'll close for the day, and requesting Dr. Vipin Sethi sir to please close today's meeting. Thank you.
Thank you very much. Thank you once again, everybody, and good for the launch of this book. Pushkar, we've got a couple of inquiries from online, and I have already told that each one of them is going to get this booklet very soon, hopefully within a week or 10-15 days time. So thank you very much once again, Pushkar, and ciao and bye bye, and we're going offline from here. You please carry on with your proceedings, and happy lunch. Thank you once again to all of you.
Thank you once again to all of you for patiently hearing us and attending the entire guideline launch. Thank you. Good day. With this, we close our guideline launch part. Thank you, Dr. Vipin.
Thank you, Mr. Pushkar. All the best.
Yeah. So with this, I'll request the next part. The next part will be having the lunch, and post lunch we will be having the certificate distribution. So to all the panel members, we'll be having the lunch since we are running out of time, and after lunch we'll be coming for the panel certificates from Professor Ochama. Thank you very much. Okay, excuse me. Attention, please. On the request of Ochama sir, I'll request all the panelists to please join us for quick certificate celebration ceremony. So I'll request the technical team to take the good photographs. Sir, let me announce the names and let you hand over the certificate. Yeah. So we seriously apologize for the sequence. Please don't mind the sequence, right? We'll invite Dr. Lauren. Dr. Lauren, ma'am, if you can please remove your mask, we will have a good photograph. Ma'am, if you can come just here so the good photograph will be taken. Mr. Ajay, please join. You can please come here. Come closer, please. And along with this certificate, we are having a memento. Please do not forget to carry. Dr. Margaret Nanjobuga. Dr. Victor Musame. Please forgive for the bit pronunciation. Dr. Michael Okello. After which Dr. Basimbe Francis. Dr. Basimbe Francis. Dr. Olivia. Dr. Epika Betty. Dr. Samuel Mutambo. Oh. Dr. Vianney. Dr. Henry. A background, please. Then Dr. Nakireka Susan ma'am. Dr. Seremba. And now Dr. Sabrina ma'am. Give a big round of applause. And please take a good photograph, please. Ma'am will not forgive. So, so on behalf of entire, yeah, so Dev is a memento gift for all the doctors who have participated apart from the panelists. And yeah, that you can do later on, right? And now on behalf of entire panel members, and all the doctors, I'll request Mr. Rajay to please hand over the bouquet to our president, Professor Ochama sir. Give a big round of applause. Give a big round of applause to Professor Ochama, sir. Thank you. And with this, I'll request all the doctors who have participated, please come and take the memento from Professor Ochama, sir. One by one, please come, please come. Yeah, please. I'll request all of you to please join. Please join. Yeah, give a big round. I'll request the panelists to motivate the entire audience for being a wonderful audience. Sir wants to say something. Hope everyone has received. So we'll request sir to please be in the middle so we can have a group photograph with the entire audience. Give a big hand to the entire audience, please. Thank you. And with this, any concluding remarks, sir?
Thank you. I think I had concluded, but you have been a very good audience, all of you. You listened, and I hope that there is something that you were able to pick from this. And really, so I didn't percuss them. I should have. But that was it was a good thing, and really thank you so much for organizing this and for making it happen. We thank you.
So Cadila team is circulating the lunch coupons. Please take the lunch coupons, and Mr. Ajay will be guiding you towards the entire venue. Thank you very much. Good day.